Greetings from Sydney, Australia. My name is Cate Madill, and it's a pleasure to talk to you about how COVID-19 has affected speech pathology services in Australia. At the beginning of the COVID-19 pandemic, we all followed a very steep and precarious curve, firstly tracking infection rates and then learning how to respond to a pandemic. We also had to learn about aerosol generating procedures. These are activities or behaviours that aerosolise droplets from the throat and mouth that may carry virus. These behaviours include breathing, speaking, shouting, coughing, singing, blowing out candles, and examining someone's mouth. What we realised is that for those of us who assess and treat patients with voice disorder, that voice assessment and therapy was now a high-risk activity for speech pathologists and ENTs. It is standard for us to assess loud voicing. We also assess how long someone can maintain the voice on one breath, the maximum phonation time, as well as the S to Z ratio. We'll assess their singing voice, their maximum and minimum pitch, which requires a prolonged vowel. In the phrases that we use to assess vocal function, there is often many aspirate consonants that produce aerosol. We'll model and train breathing exercises, as well as loud voicing and speaking exercises as we rehabilitate and reorganise vocal function. And we'll also conduct aerodynamic assessment, as you can see in the picture on the slide, which is of course very high risk for aerosol and droplet transfer. So we protected ourselves by wearing a mask. This, however, is not a simple and straightforward solution, as there are many factors we need to consider. Because there is an impact of wearing masks. We have to think about what type of mask we use, because the reduction in the risk of transmission is dependent on mask type. What we do know, though, from our current research, is that the better the protection, that is, the reduction in risk of transmission, the greater the impact on sound and speech. Our current research indicates that the frequencies that convey consonant information is heavily impacted by wearing of masks. This in turn then has a direct impact on the clarity of speech, and we're currently running experiments to assess the effects of masks on intelligibility. There's an impact on voice therapy modelling because we often need the patient to see what we are doing with our mouth, tongue, jaw, throat, etc. And there is a direct impact on the patient of wearing a mask as they report to us. There's an impact on their breathing, and for those with upper airway disorders such as inducible laryngeal obstruction, or who struggle or feel breathless when they are voicing, this can be quite distressing. The physical comfort or discomfort of wearing a mask can be a big problem for clients. The effort that they have to use in phonation, this is reported to us regularly. And they also report a sense of a lack of connection between the client and the clinician as a result of having to wear a mask, and also the clinician wearing a mask. The Australian Speech Pathology Association quickly developed recommendations for speech pathologists to minimise their risk of infection from the virus when the pandemic first emerged. We defined what aerosol generating procedures were and which ones are of higher risk. These included clinical evaluation of swallowing, video fluoroscopic swallow studies, flexible nasendoscopy, evaluation of supports for mealtime assistance, cough or gag reflex testing, loud voicing, singing, voice assessment tasks, instrumental respiratory and aerodynamic function testing, speech pathologist-led laryngectomy care and management, tracheostomy care and management, swallowing or communication assessment or intervention with clients requiring non-invasive ventilation, high flow nasal oxygen, respiratory support via nasal cannula or face mask, or clients with difficulty with saliva control or who were exhibiting distress, such as crying or yelling. A list of very high-risk aerosol-generating procedures were identified, and it was recommended to undertake these only if essential to client care and management. These included flexible endoscopic evaluation of swallowing or FEES, endoscopic assessment of vocal function, testing of the gag reflex, voluntary cough testing, cough reflex testing, and instrumental respiratory aerodynamic testing. A guide for clinicians to follow in terms of consultation and conditions under which to conduct these activities was also formulated, confirming appropriate actions with the current restrictions with healthcare authorities, the fact that consultation must be conducted in an appropriate location with appropriate approvals, delaying any aerosol generating procedures, if there was a need, an essential need to conduct speech pathology intervention with a COVID positive patient, that appropriate PPE not only be available, but be worn appropriately. And if appropriate PPE could not be provided, that the speech pathology intervention would not be offered. So this resulted in a process of triage and prioritisation, which is described in detail in the slide. And this was designed to help their decision-making about when or if they should see their clients. As you can see, it's quite detailed, and it certainly provided much needed guidance very early on in the pandemic. But there was certainly a lot of confusion and overload of information for clinicians at this time, as it was, I think, across most healthcare settings. So the primary recommendation was to opt for telehealth, that is, video conferencing like we're doing now, obviously live, or via telephone. And this was recommended when the client or the clinician is at risk, when the service is not essential or preferred, that is, it's preferred to not do face-to-face physical interventions, when the effectiveness of the service is equivalent, if appropriate precautions and protections are unavailable, and if the service couldn't be provided in a workplace. So, for example, when schools were closed, a lot of speech pathology services were provided in schools, so this prevented the service being offered. But if the patient was considered essential to be seen, that they have a physical face-to-face intervention, then the risk of transmission needed to be assessed. So this meant considering the client's age, given that elderly people were more at risk of not only getting COVID, but having very poor health outcomes as a result of it, their health, their home environment and location, was that one, whether they were in a hotspot, whether if any of their family members or people they had contact with were at risk, and also the client's ability to self-regulate their behaviour and comply with instructions. In considering the risk of transmission, we also had to consider the client, the clinician, and their own risk factors. So their age, their health, their home environment and location, and their work environment and location. That is, were they hotspots for infection? Were family members or community members that they lived or worked around at risk of transmission? The proximity of the client in the intervention was also necessary for the clinician to consider. In some cases, it is necessary to sit very close to the client to deliver the intervention, and this obviously creates a higher risk. Was there a need to use aerosol generating procedures in the intervention? Were there cleaning protocols in place? and adequate supplies to undertake those protocols? Were barriers and distancing measures in place? Could we have screens on the desk? Could the client sit more than 1.5 metres away, ideally 4 if possible? And could the clinician access and correctly use personal protective equipment as required? So once all of this was considered, then a range of risk management recommendations for seeing clients face-to-face in physical proximity was developed. This included a risk analysis prior to making the appointment, so asking the client a range of questions. Those being their health, their overall health, and the symptoms not only at the time of booking, but on the day of the appointment. Ensuring they spend as little time in the waiting room, maintaining 1.5 metres distance away from others, and ideally one person every 4 square metres. If we were unable to maintain a distance of 1.5 metres, then using standard precautions, which I'll mention in a moment. Trying to limit interactions to less than 15 minutes if possible, and if longer than 15 minutes, interaction, again using standard precautions. Using barriers, directional adjustments such as asking the client to turn away and face a window that can be wiped down, or a very large area where there'll be no contact droplets when doing aerosol generating procedures. And if not possible, ensuring that there was PPE available. Cleaning and disinfecting between clients is required, not just touch points such as desks, reading passages, etc., but also microphones and the socks or the covers on the microphones as well. And finally, ensuring adequate ventilation, ideally during the entire interaction, but as a minimum between clients. So ensuring that the room was completely ventilated between clients. So briefly, what are standard precautions? Just to make sure that we all understand what we're talking about. They are work practices required to achieve a basic level of infection control. They include hand hygiene and cough etiquette, that is coughing into your arm or a tissue and discarding. The use of personal protective equipment, the safe use and disposal of sharps, routine environmental cleaning, and incorporation of safe practices for handling blood, body fluids and secretions as well as excretions. So this was the first phase of the response to the pandemic and the high transmission risk in the first phases of the pandemic. In June this year, so 3 or 4 months in, myself and a team of speech pathologists developed an online risk assessment tool for other clinicians to use to assess the risk factors we've just discussed when seeing patients. So instead of using a written triage and prioritisation written tool, we put the risk assessment online to supplement the written material. This resulted in what we call SPARIT, the Speech Pathology Australia Risk Assessment Tool, and is freely available through the Speech Pathology Australia website. It's designed to assist speech pathologists assess the number and type of risk factors for transmission of COVID-19 that may be present in any in-person clinical scenario or physical face-to-face interaction. So the tool is there to support speech pathologists to make a decision themselves. It's not a decision-making tool. It's based on constantly emerging evidence, so it is updated, and it is also considered a way of synthesising that constantly emerging evidence. There is a video discussion on how the tool was developed and used, and the link for that is at the bottom of your slide. So how has COVID-19 and the pandemic affected speech pathology private practice in Australia? So as an example, in my own private practice, before COVID-19, we saw 90% of our clients face-to-face. After or before, they'd been referred to the ear, nose and throat specialist. We provided telehealth services nationally and internationally to approximately 10%. We collected data in the office, face-to-face, to track progress in therapy, or as the ENT diagnosis provided or indicated. And we would always refer to an ENT for visual imaging of the voice box and confirmation of diagnosis. Now, things are very different. At the time of writing this presentation, ENT surgeons were only then starting to see patients again. So we were seeing 90% of our clients by telehealth, and many of them had not actually been able to see an ENT or have an endoscopic evaluation. They had only had a telehealth consultation with the ENT themselves. So the diagnosis was very much one based on case history and symptom presentation. So that raised the imperative for us to collect a lot of data so we could be confident and get more information about a possible diagnosis. So we needed to collect all of our data online. Now, given the transmission risk of degradation of the signal over telehealth, we developed protocols for the clients to collect data themselves using free online software and as good a quality microphone as they could. We asked them to fill out relevant patient-reported outcome measures such as the Voice Handicap Index 10, the Vocal Tract Discomfort Scale, the Reflux Symptom Index, and the Singing Voice Handicap Index, just as an example. We worked, as I say, with our clients to get as high a quality audio recordings as we could, but of course this was very difficult because we weren't in control of the recording equipment ourselves, so we couldn't necessarily ensure that the recording conditions were the same. But we still continue to conduct a comprehensive functional assessment and use consistent and standardised measurement protocols. Again, this is essential because high quality, consistent, comparable and frequently collected data is absolutely necessary to inform the diagnosis when we don't have a visually confirmed ENT diagnosis and to measure outcomes. Things are constantly changing as the management of COVID-19 changes. So we are constantly adapting to changing recommendations. We currently use the risk assessment process following the SPARAT tool, and we are using the new telehealth speech pathology first contact model that Chris Payton has described for you in another presentation. We've updated our online consenting procedures, data collection and security procedures, since we are now so dependent on them. We continue to triage and do 2 pre-consult contacts with our clients to make sure that they remain low risk or to understand their risk profile. We continue to stagger appointments so we have less people in the waiting rooms. And we continue to implement policies and procedures that continue to change in response to the changing conditions. We're washing our hands a lot, and we're using a lot of hand sanitizer and alcohol wipes, which we didn't previously do. And we are trying to keep a sense of humour. As our transmission risk now in Australia is very, very low, and we have very minimal local transmission, we're now seeing COVID-19 negative patients and low risk patients face-to-face more often. certainly for data collection at first in their initial consultation, if in fact they're comfortable and able to do so. We previously kept this to a 15-minute minimum, but as the infection rate reduces, as our policies and procedures for infection control and risk reduction are now standard, we are feeling way more comfortable seeing patients for up to 60 minutes at a time, especially also now we have much more available PPE and can follow standard precautions. We're still using telehealth service delivery and we primarily use Zoom, but sometimes we use FaceTime or WhatsApp depending on the client preference. We still continue to support patients to attain the best recordings between any face-to-face physical interactions so that we can compare those recordings to again track progress. We continue to standardise data collection procedures across all sessions, and sometimes our patients need some help to keep that level of standardisations. And we are using online tools that we've developed for our clinical practice to chart the data so that not only can the patients see their progress, but so too can the clinicians. So that sees the end of my presentation. I hope the information contained therein has been of assistance, and should you want to find out anything more or get more information about what we're doing here in Australia, please feel free to contact me via the email you see on your screen. Bye for now.